At the outset, I would like to express my profound thanks to Professor Khanna for organizing this educational platform and providing me the opportunity for this event. The topic of my presentation today is the role of NOx in the management of venous thromboembolism. These are my disclosures, and today I will be focusing my talk on these outlines. At the outset, we'll talk about the general principles of anticoagulation in venous thromboembolism. Today's talk, as in general, is essentially includes patients with deep vein thrombosis or pulmonary embolism. We will later move to the selection of anticoagulation in different situations and specifically focus on the role of NOx both in the acute management and the long-term prophylaxis of thrombosis. In the end, we will talk about certain specific situations in this field. So why do we use anticoagulation for patients with venous thromboembolism? The most important rationale for treating patients with DVT is obviously the recanalization of the veins so that we prevent the occurrence of pulmonary embolism as well as minimize the chances of compartment syndrome as well as the long-term the post-thrombotic syndrome. Similarly, for management of established pulmonary embolism, the first rationale is to obtain the hemodynamic benefit, which helps in the management of acute heart failure that develops, and subsequently to reduce the development of chronic thromboembolic condition. And the anticoagulant is also used to reduce the recurrence of DVTP in patients, which is very high, almost 25% at 5 years. And finally,
Dr. Malik, so can you please sit closer to the laptop, please? Your voice is fading away sometimes.
Okay, is it better now?
Yes, sir.
And anticoagulants are finally used for preventing, in the first place, venous thromboembolic events in patients who are at high risk, like those who are hospitalized or have other immobilization or other conditions. The minimum requirement, some patients of venous thromboembolism can, of course, be managed on a ambulatory or outpatient basis, but they have to be ambulatory, hemodynamically stable, have a low bleeding risk, and do not have severe chronic kidney disease. And there has to be a practical system in place for administration as well as monitoring of the anticoagulant agents, as well as surveillance and timely treatment of any recurrent VT events or bleeding events. So there are 3 groups of agents currently available for the treatment of venous thromboembolism. The classical ones are the parenteral anticoagulants, heparin and low molecular weight heparin, and now later on the fondaparinux was also added. Among the classical oral anticoagulants, we have the vitamin K antagonists, known as the warfarin-like agents. And finally, we have the novel oral anticoagulants in which we have factor Xa inhibitors and direct thrombin inhibitors. We'll be discussing these in detail. The selection of an anticoagulant for VTE is predominantly dictated by its efficacy, safety, availability, and the need for the reversal of anticoagulant. The other factors which are important in this context include the presence of other comorbidities, the clinician's experience, and there are some special clinical situations. Of course, the values and preferences of the patients are also to be kept in perspective. An ideal anticoagulant should be efficacious, safe, including during pregnancy and in children, easy to administer, have rapid onset and offset of action, have a predictable therapeutic half-life, and immediate reversibility if needed, and no need for or minimal need for monitoring, and few diet or drug interactions, and be affordable. But currently, none of the available anticoagulants fits all these criteria. There are relative merits for all the agents. This is a busy slide. We can be referring to it later on. Both the parenteral and the oral agents have their own merits and demerits, which will eventually play into the selection of an individual agent, of the anticoagulant agent for individual patients. The novel oral anticoagulants, which is the topic for today's discussion, in this term, the N stands for the novel, but it has been also defined as standing for non-vitamin K oral anticoagulants. In the latest CHESS guidelines of 2016, it was proposed to stand for the non-vitamin K antagonists. There are other acronyms which are also used for this, especially the direct oral anticoagulant or DOACs, sometimes which is now even preferred. Other terms like TSOX, ODI, SODA, also being variously used from time to time, but they're unlikely to become familiar in the near future. The available NOACs include the factor Xa inhibitors like rivaroxaban, APVIC-7, edoxaban, and the late batrixaban, well as the thrombin inhibitors are the dabigatran and the zigalagatran. Why these NOACs came into front is based on the central role of factor Xa as a gatekeeper in the coagulation cascade. You can see it is positioned at the start of the common pathway of coagulation, and therefore interfering in the activity of factor Xa is going to be, of course, theoretically going to be very helpful in managing the coagulation cascade. The direct factor Xa inhibitors exactly do the same job. They engage the active site of the factor Xa molecule activated and inhibit both the free factor Xa in the plasma and that attached to the prothrombinase complex. These agents are orally administered and have many of the properties of an ideal anticoagulant that we discussed before, like they are convenient, do not need monitoring, effective, they have been shown to be non-inferior or even superior to the conventional warfarin therapy. They are safe and they are used in fixed doses and have rapid onset and offset action and have a predictable pharmacokinetics and dynamics. However, they have certain limitations like the antidote, which was not available. Although antidotes have been available recently, but they are not available for most of the patients. They are costly and cannot be used in poor patients with severe renal disease and kidney disease and liver disease. And there is limited data on their use in children and therefore in pregnancy and oncology patients. So the NOACs, although having many of the properties of an ideal anticoagulant, still are not ideal and have their own limitations. The rivaroxaban was the first and one of the first among the NOACs. It is used in the prophylactic use in VT was established in the required group of trials in the hip and knee, later in the knee arthroplasty, and in the medically ill patients in the Magellan study. It was approved by FDA in 2012 for the treatment of DVT-P and for the reduction of recurrent DVT-P after initial treatment. A pooled analysis of the Einstein DVT and Einstein P trials has shown that rivaroxaban is as effective in preventing VT recurrence and as enoxaparin followed by VK therapy with less bleeding device. APVIC-7, its role was as in prevention of DVT-P was established in the advanced group of trials and in the hip and knee replacement cohorts and in the medically ill patients in the ADOPT trial. It was approved by FDA in 2014. The Amplify study established that in comparison with standard anticoagulation regimen, APVIC-7 resulted in a 16% lower risk of composite endpoint of recurrent symptomatic VT or VT associated death. Edoxaban was approved by FDA in January 2015 for the treatment of DVT and P in patients who have been initially treated with a parenteral anticoagulant for 5 to 10 days. The Hokusai VT study showed that among patients with DVT and P, edoxaban not only was non-inferior to high-quality standard warfarin therapy, but also caused significantly less bleeding in a broad spectrum of patients, including those with severe pulmonary embolism. About the betrixaban, it was approved in 2017 by FDA for prophylaxis of VT in adult hospitalized medically ill patients. Its role was established in the phase 3 APEX studies. Betrixaban group showed significant decrease in VT events compared with the enoxaparin group in this study. That was about the direct 10 inhibitors. About the direct thrombin inhibitor, which is currently available, is the dabigatran. It is a competitive reversible thrombin inhibitor, inhibits both the free and fibrin-bound thrombin. It is orally administered as the prodrug dabigatran etoxylate. It was approved by FDA in 2014 for the treatment of DVT and PE in patients who had been previously treated for 5 to 10 days with a parenteral therapy. And it was approved later for secondary prevention of DVT and PE in patients who had been previously treated for the acute. Other agents in this class of direct thrombin inhibitors are the argabatran, melanogatran, and zamilagatran. Their development was stopped by AstraZeneca because of reported hepatotoxicity.
Dr. Malik, please conclude your slide. Your time is over.
Okay. I will be moving quickly through my slides now. This is a summary of the different trials which established the role of NOACs versus warfarin for acute treatment of DVT. You can see that they had similar efficacy, while as the bleeding was significantly less in the NOAC group of patients. Not only that, NOACs were also shown to decrease the resource utilization in treated patients compared to low molecular weight. So to conclude about these, for general population of VT patients, oral agents are preferable to parenteral agents, and NOACs are preferable to the agents, and they should be the first choice for most hemodynamically stable non-pregnant patients who do not have severe renal disease or cancer. Rivaroxaban and ibexaban are administered as monotherapy, whereas edoxaban and dabigatran are administered only after prior 5 to 10 days of parenteral therapy. An ideal patient for NOAC, as I said before, should have good renal function and hepatic function and should be adherent, whereas patients who have these issues or have active cancer are not ideal patients for NOAC therapy. There are certain clinical factors that would influence the agent selection for anticoagulation, like cancer patients are better treated with low molecular heparin, liver disease, again, low molecular heparin, and GI bleed on the APVIC. This is a busy slide. We can refer to it in some other detail. There, in cancer patients, lately there have been several studies which have studied the role of NOACs among the oncology patients, like the Canvas Pragmatic, the SELECT-T, the ADAM-VT trial, and the Hoxsite cancer component. And they all concluded that NOACs offer a simple oral treatment regimen alternative to the low molecular weight heparin. However, the risk of GI bleeding has to be considered significantly. These two trials, the AVERT and Cassini trial, were recently published, which studied the effect of NOACs in primary prevention in high-risk oncology patients. So clinical considerations, optimal patient for an oncology patient would be patient without a GI malignancy and who doesn't have a major bleeding risk, and when the patient prefers the easy treatment and there are no drug-drug reactions with the chemotherapy. In the long-term prophylaxis of DVT, again, clinical scores, there are two competing concerns, like risk of recurrence versus risk of bleeding. The risk of recurrence is about 10 to 40% at 12 years, 20% at 5 years. And there, for the bleeding risk, there are several scores to predict the recurrence risk, but for the risk of bleeding, there are currently no well-validated tools to stratify, but these are the risk factors which would increase the risk of bleeding on anticoagulants in the VT settings. So how long we treat, this is a summary of how long we should treat a patient with, depending upon the clinical situation, whether it's a proximal or a provoked first or second event. And accordingly, we selected the duration of therapy. And this is we will see what is the role of NOACs in the extensive treatment. Both rivaroxaban as well as APVIC have been found to be useful in the long term in reducing the recurrent against the placebo group, although there has been a slight increase in the bleeding risk in these trials. The Einstein choice trial compared the effectiveness and safety of rivaroxaban versus aspirin for the long term prevention of venous thromboembolism in patients who had already been treated for 6 to 12 months. Among these patients, the risk of VT recurrence was significantly reduced by rivaroxaban, both at 20 and 10 milligram doses compared with aspirin. So this is a summary of the trials which has studied the long-term use of secondary prevention role of NOACs. For the dabigatran, we have Remedy and Resonate trials. For the rivaroxaban, we have Einstein group extension study, and for the XIII, we have Amplify extension study. All these studies showed a significant superiority compared to placebo in the prevention of recurrent VT. However, in the rivaroxaban and dabigatran group, the risk of bleeding was higher in the long and extension trials. This slide is sometimes we need to switch between the anticoagulants, so we have a different protocols have been developed for switching between VK to NOAC and as well as NOAC or a NOAC to VK. NOAC reversal agents have recently been developed, including the adrasuzumab and the lately developed indexinate alpha. Indexinate alpha was recently approved by FDA for the reversal of NOAC anticoagulation. There are some other newer anticoagulants being developed, including the allosterotic thrombin inhibitors, which appear to be promising. And there are some more studies being conducted, including those in the COVID-19 thrombosis prevention trial. And these should tell us more about the role of NOAC and any limitations and other unanswered questions about the NOAC therapy in venous thromboembolism. So to summarize, VT is a common disease with high risk of mortality, morbidity, and recurrence. Anticoagulants are the mainstay of treatment for VT, and NOACs are generally preferred for acute and subsequent treatment of VT. NOACs should not be used in severe renal failure and those with severe renal liver disease. If used in patients with mild CKD, we should check the renal function at least twice a year. NOACs may facilitate outpatient treatment of acute DVT and low-risk PE and facilitate a shorter hospital stay. The recent availability of NOAC antidotes may further broaden the scope and usage of NOACs in venous thromboembolism. The minimum effective duration of therapy with NOACs is about 3 months. Select patients may benefit from extended anticoagulation, and we should consider individual risk-benefit ratio for extended therapy. Sometimes D-dimer, ultrasound, and clinical scores can help in this direction. Thank you very much.
Thank you, Dr. Malik. It was a wonderful talk and a lot of information available.